So 65-year-old lady, vascular path, all the risk factors, claudicant, not rest pain essentially, less than 1 block on optimal medical therapy. Bilateral pulses were Doppler, non-invasive workup, significant abnormal ABIs, arterial Doppler done, shows monophasic left-sided waveforms. Patient has a prior history of left iliac stenting placed 5 years ago, or 4 years ago. Comes in for evaluation. So I guess from the complication standpoint, the first and the most important thing is when you know why the complication is going to happen is the wrong side of access. So remember, with the left leg, we're supposed to get it right. By the time I go into the room, or whatever, the fellow already has the access. But this is the only slide I'm going to, complain about the fellow. So we got a left-sided access. You can see there's significant disease of the iliac. First, there's is it a dissection? Is it wrong side? Sometimes you can't feel the wire. But anyways, we did a small test. It was more of a significant iliac disease. So we got a right-sided access because that's what it was. It was a micropuncture sheet, so we took it out, held pressure. We got a right-side access. You can see the right side. The runoff looks great, nothing crazy, except for there's a CTO at the end, and that's what justifies the abnormal ABI on the right side as well, and significant below-the-knee disease on the right leg. So here you can see we got an iliac angiogram. You can see a left-sided iliac proximal occlusion, ISR, with the nub right there, with distal reconstitution at the external iliac, almost extending up to, but you can see all the way to the external iliac, the distal part of the external iliac. So patient is a claudicant. There are multiple options, I guess, because we're talking about the complications part, we're going to focus on that. But it's not it is an ISR. There are multiple options. You can keep the medical management off, forget about it, but it was really lifestyle limiting. You could do intervention of the iliac ISR, or worst case, if you can do a fem bypass. But because it was the first time ISR, patient active smoker, we wanted to give it one more try before we called the surgeons, which eventually I had to call Dan as a backup because Ajit was on call on the other side of the park. So we got this. So we decided to intervene on the left ISR. The question was, how do we intervene? You can already see the left axis was horrible, so there was not much room to put any sheath or do access. The right side is virtually technically hard to access anyway, so the only option left was the left radial. So we went up the left radial axis. Multiple pictures we took just to define the anatomy. You can see the distal runoff of the left SFA and some below-the-knee disease. So multiple orthogonal views. You can see a nub in the stent with ISR right there. So here you can see my R2P sheath all the way down into the distal aorta. So the question is, it was a lady, short. I know the teaching again is 7 French, iliac, salvage, visualization, deliverability of bigger stents or anything which complications happens. But in this case, we were hoping we'll give it a shot. If we fail, we're going to call it today and just let the surgeons decide or let the patient stay what it is. So anyways, we got a 6 French left radial axis, 035 stick angle glide wire with a catheter. We crossed it. We took multiple views just to make sure that we are orthogonal. So we go all the way from ipsilateral to contralateral, and we're completely within the stent. The wire is across. You can see into the external. Everything looks good. We balloon dilated serially to get my balloon dilatation of the ISR. Now this is the picture after the opening up of the left common iliac. You can see some external disease. So there was an outflow issue. So keeping in mind, lady, we decided to took some pictures again. This is the distal runoff, looks good. So we put in a stent in, 70 self-expanding stent, 7060, in the external iliac, and we post-dilated with a 7040 balloon. Not aggressive, just wanted to make sure the outflow is there. But there's one issue you can see right here. If you look closely, you can look at an outpouching coming up on next to the iliac crest bone. I don't have a mouse to see, but I'm sure you can appreciate the iliac crest. You can see you see where the balloon is, and there's a small outpouching.
That's the lateral aspect.
Right, the lateral aspect. Where's the?
Yeah.
Hold on. Do we have this?
No, I can see it.
Right. So I guess that's a sign that you are going to get into trouble.
Is the patient complaining of pain at this time?
No pain. She's completely stable all throughout, before and after the complication.
So how did you size your stent?
It wasn't an IBIS because I didn't do it. I was just more a visual assessment saying, okay, external iliac, self-expanding. So, yes, go ahead.
Oh,
I thought you had a person. So visual assessment. Like I said, I didn't want to be aggressive enough because the vessel wasn't that big, maybe 6.0, and I used a self-expanding stent, so I think a 7.0 was an appropriate size, keeping in mind the luminal diameter. So we just wanted to do a slight balloon touch-up, make it uniform, and get out. And
oh wow!
right, exactly. So
oh, and look at the clot coming
That's
up.
a Hiroshima.
right. So the issue is we had used heparin. The ACT was
Oh, I like the clot.
the 302. Exactly. That's the fun part of the story. So the ACT was 302. We used heparin before we started, and you can see now a clot and a perforation at the same time. And now you have a 6 French sheath. We go up with the balloon. Of course, we take the same balloon 7.0 down, balloon tamponaded. We take an injection shot just to make sure we are tamponaded and there's no dye going down. And this is after the ballooning. So you can see the perforation is sealed. Patient was always stable because of a quick recognition. There was not even a drop of mercury or blood pressure on her. But the biggest problem is the clot sitting right there now. Usually the teaching is you will reverse your anticoagulation. We just repeated the ACT for documentation purposes. It was like 218, 221. So it wasn't that crazy high, but it wasn't that crazy low as well. So, but we didn't give any protamine because the patient was stable, perforation had stopped, and now we're stuck with this clot. So you take some pictures and it's sitting right there. So the question is what to do now. So the happy face is sad face. One problem solved, second problem comes up.
This question.
Say what? Oh, good. So exactly. So now the issue is since I have a path in there, since I already had a right to access, I took a 7 French system this time, up and over because the CT is closed, and I took a wire down and I put a filter in. Usually iliacs, you want to really use 035 system for more pushability, getting all the big devices. But in this case, I don't want the clot to go down all down the leg, especially the SFA looked good.
So how do you know it's clot, right? I mean, your ACT is therapeutic, you're on antiplatelet agents, and you just went through a sort of chronic occlusion in-stent restenosis, and now you've got this filling defect. So how do you know it's clot?
Well, that's a good point. I mean, it was just, you know how it is. The teaching is if it's an ISR, there's always a component of thrombosis, chronic clot sitting in there, in addition to fibrotic tissue. So you're absolutely right. Could be fibrotic tissue as well, which I displaced, overlying thrombus, or because my ACT repeat was 221, 220, maybe, I don't know if she had some underlying issue, but it wasn't there to begin with after I did my first balloon angioplasty and after I put my external iliac stent.
Because when you injected is when it went down, and Dr. Ferris is probably right because it went down, so
Correct.
It might have been something from within the stent
Right.
that was just going down.
Yeah, absolutely
Chronic
right.
clot, certainly. Yeah,
Right.
but probably not acute thrombus.
No,
Correct.
it's not the thing that formed at this time. Your ACT was okay, but iliac disease, even without in-stent restenosis, is notorious for this. And in-stent restenosis is even worse.
Right, exactly. So we put a filter down and NAV6. We did multiple penumbras. I used technically do the whole canister of penumbras, and hemoglobin went down because of penumbra and not because of my RP bleed. I can guarantee you that. And the clot/thrombus is still sitting there.
This needs a covered stent.
Okay,
Yeah.
so look at the picture closely. So I get a covered stent in there, but can you see it is pre-deployment? Can you see what the problem with the covered stent is?
You went from, you got to go to lateral. That's
No.
But you can expect a penumbra. It's not wrong to try the penumbra, but you can expect it to not work because it's going to be either
Too bad.
chronic thrombus.
No, the
or
coverage
some
stent is
fibrosis.
on the side of the stent.
No, the problem is I stripped my covered stent.
Yeah.
So now my covered stent got stripped because I was planning to, like you said, exclude my thrombus/fibrotic tissue. The only way to do that was put a covered stent in. So I got a covered stent to exclude it, but because it's an 014 wire, stiffer section ISR, and I pushed it through, and trust me, I was very gentle, no nudging, no, like the shake movements we do, nothing at all. It got stripped. The good thing is it got stripped right where the exclusion was. So I took a tour, you're going to see. So I took a tour balloon because my wire was across, expanded the stent, covered stent, then took a bigger balloon. And let's see.
Well, what stent was it? Was it an atrium?
This was a live stream.
Oh.
So this is, I took serial dilatation, sorry.
So my question is when you,
He wants to break free.
Hold on, can I play the,
so Vishal, when you had the perf there, at that point,
can I play the last two pictures? Sorry, I don't have control.
Did you not consider getting ipsilateral axis and doing the rest of the stuff?
What do you mean? Like
The right panel. Play the right panel, please.
the right side. Yeah, I'm just the right side. I just showed just to document that my lower below
okay.
the
No, no, I
runoff
mean-
was exactly the same, and I had good outflow.
When you had the perf, did you not consider sticking the left groin and
Well, the perf was more distal, and the left groin, I didn't want to start manipulating
Okay.
things around it.
Yeah.
I already had a right-sided axis, 5
so you
French,
just went in up?
and because I had opened my lesion proximally, I was able to put my sheath up and over and have still control over it. So that was the reason I used left, and I wanted to increase my size through a 7 French. So I wasn't sure how far I'm going to go up and distant down. So I didn't want to start poking around. God forbid my wire goes through the perf hole or something happens. So I just wanted to avoid minimal manipulation on the ipsilateral
I
side.
just want to notice that the sheath could have been like 10 millimeters down, so it's a little bit more aligned with the vessel. That might have helped a little bit. You know that the right femoral sheath, while placing it, might have been a little bit. It could have been a little bit more in order to
Right.
align better. Right now, it kind of
it's basically like
throws
coaxial.
you through,
Correct. Exactly.
puts you through right next, and probably that's where you
Stripped it.
the stripping started and then kind of continued slowly. But everything went very well. And again, there's a little bit of a stenosis right after the problem, and I think that's when the cover stent got stuck. So somehow got perfectly placed.
Nice case.
That's a great result.
Very good.
Great case.
These
Okay.
covered stents are notorious
Yep.
for coming off the balloon. So just
Horrible.
if you can deliver
Like-
them through your sheath, you're better off. But in this case, you couldn't.
Yeah, that was my goal. But with all this perf and things going on, we just wanted to exclude it and not end up with distal embolization. Now we are CLI because it's somewhere in the common
The
femoral.
only thing I would say is I agree with Bhaskar. You already have a perforation. You have a bunch of stents to go through from the right to the left. You're not going to be coaxial. You could probably aspirate through the left groin. I would have probably got the left groin access, make it a 3-access case, and go ahead and fix it from below because your covered stent wouldn't have stripped, and you probably might have been able to even aspirate or get better aspiration.
That's fair.
I have a small comment. Sometimes in similar situations of thrombus in coronary, we control the heparin by protamine and inject glycoprotein 2,3A inhibitors or lytic therapy, even lytic
But
therapy,
remember, it's a
2B3
intravascular.
No, but the patient had a perforation.
Can't do anything.
I speak about the thrombus after controlling the perforation, about the thrombus instead of cover the stent as long as the perforation is already
So
sealed.
you really trust your covered stent, huh? 100%.
No.
Wow.
It
I
wouldn't
didn't
work.
have the-
It wouldn't work for this. You've got chronic thrombus in there with plaque. It's okay in coronaries in acute situation. It wouldn't work up here.
And you can
It may be acute. Sometimes small dissection may trigger this thrombus.
Not with an
acutely.
ACT of 280.
No, I don't think so. But you should be careful giving a potent, anticoagulant, stats, a platelet inhibitor in a patient. You have a perforation, even if you have a covered stent, and you have 2 accesses, potentially 3 accesses. So you should be really careful. And like Dr. Sachar said, it likely is not acute; it's probably chronic. Okay. All right.